All right. Good morning, everyone. So we'll present the second case. So this is the part of the team that participated during the care from neurosurgery, radiation oncology, neuroanesthesia, and the ICU, of course, who takes care of the patients right after, immediately after surgery. So this is a patient in his 60s that had an incidental finding of a left frontal skull lesion. This was found during workup for carotid stenosis by his local neurologist. They did a full body scan and another solitary renal mass was found at that time. On retrospect, the patient did mention that he was having some progressive fatigue, headaches, and some local tenderness in the area of where the skull lesion was found. This was, getting progressively worse and was affecting his work and activities of the daily living. Past medical history was significant for coronary artery disease, which he underwent 3 stent placements, carotid endarterectomy, and the patient was aspirin and on aspirin and Plavix, which are some things that we need to consider before we put a patient through surgery. Physical examination was unremarkable. There was nothing altered. And this is the CT scan from the time,
Before
the
before
first.
you before you move on the physical examination, I'm gonna ask Dr. Ravindran. All right, physical examination. You hear the story already. Common things happen commonly. Someone calls you about this case, and they're telling you that there's a mass, and they feel the mass right here. What would be your thinking as you go into that room to do an exam in history as to help you differentiate whether this is something benign, whether this is something malignant, whether this is something that you need to deal with quite rapidly? I think that you're muted, Krishna. Oh, but I think that Krishna may be signing out or something. I see him moving his hand and doing all kinds of stuff. You know what I mean? So he is doing something else.
Preparing for something, preparing for
Yeah,
something.
he's preparing for something. I think he's in a meeting or something. I'm gonna go then to Allah. Allah, you there? They may all be in the same
Yeah,
in the
my
Yes,
guess is
sir.
that they're all
No,
in the same room.
they're all in the same
I'm
room.
in a different. No, no, I'm
Okay,
in a
good, good.
different room. I'm
All
in the
righty.
hallway.
So yes, Allah. So just teach our fellows and our residents right here. So you're concerned about this, or you're being called, and you want to go in and you want to get a sense as to whether this is a benign process or a malignant process. And they're telling you, you're about to go and get the physical examination. What would be your thinking process and you're looking for?
Well, I'll see the lesion. I'll kind of like inspect the skin overlying and see if there are any concerns with kind of like skin invasion or necrosis, etc. I'll see if the lesion is painful or tender, and
Beautiful.
palpation as well. Tenderness would help me with the differentiation.
Yeah.
I would also try to get a better feel of the bone around the lesion, whether I can feel edges or no, whether there are satellite lesions around.
Beautiful.
All these would help me. And also, I would like to examine the patient like from head to toe, looking for other, lesions as well, or
Yeah.
other palpable
Beautiful.
lesions. Yeah.
Yeah. In general, malignant lesions tend to be, more painful. They tend to have all
Right.
those characteristics
They
that
tend to
you
be more
described.
painful and
Mhm.
tender. Right.
Yeah. Beautiful. All right. That's what I want because we're about to, because, Andres just passed through the physical examination, but I think that you can learn a lot from the history because you're going to see the images right now and it is pretty scary.
One thing that came up
Yes.
when I was talking with him is, he could feel this mass, but he told me he could feel it for at least the past 5 years. And so
Amazing.
that to
Yeah.
me suggests a very slow process as well.
Gotcha. Thank you, Jennifer. That's very, very good.
Yeah, thank you. So I'm gonna show the first CT scan that was obtained when the lesion was found, and you can see the mass right there in the left frontal skull. Looks like a lytic mass that's eating away the bone right there. I don't know if Dr. Gupta wants to make a comment on the CT scan.
Sure. So as you can see, there are a few things happening simultaneously radiographically. One is that the bone is expanded. You can see that and you can see kind of this sort of a striated, if you can call it, remodeling of the outer table and inner table. And there are clearly areas where there's some excess bone, which is the hyperostosis, and there are areas where clearly the bone has been lost. Here you can see that bone has been lost, and it's hard to tell on CT whether or not there is some extra osseous component to it. But you can see that it has these sort of small, what we often call as a sort of a starburst sort of appearance, where you see this sort of linear striations through the sclerotic bone. I mean, of course, I'm not going to give away the diagnosis right away, but it has some very typical features of a certain entity. Now, let's just talk about what it doesn't look like on imaging. So most of the metastatic lesions of the skull are by and large purely bone destroying lesions, with the exception of prostate and breast cancer, which can have hyperostosis associated. So we can't entirely rule out this being either, I mean, was it a male or a female? It was a male, right?
Yes.
It was a man.
Male,
So,
yes, male,
correct. So I think you do entertain the possibility of this, a certain kind of sort of a lesion coming out from cancers that can cause some new bone sort of formation. Now the other things, like sort of most of the metastatic lesions from solid organs are generally lytic. They don't have so much of bone formation, and they grow so rapidly. They're so malignant that they don't allow bone to form. And things like myeloma are also purely lytic, and they have very sharp sort of clean cut margins, and they destroy the bone rapidly. But I think if we are considering the possibility of metastasis, we are largely thinking, it could be prostate, but unlikely to have a solitary met in the skull and no disease elsewhere, and not a known disease. So the first presentation of prostate cancer as a skull met is unlikely. And there are other entities like osteosarcomas, which can have an appearance somewhat similar to this, which can have some periosteal new bone formation, some endosteal bone formation, some area of sort of lucent. But again, from the history, osteosarcomas are very rapidly growing tumors, so that would be rather unlikely. So I'm just leaving out the entity that I think it is for later.
But incidentally, Vivek, when we look back at the history of the readings and stuff like that, Mark and I are communicated. Everybody was pretty much saying this is metastatic cancer. You know what I mean? It's like, but let's see what we find.
So I'm gonna show the coronal cut of the MRI that was obtained. So you can see the lesion in the skull right there, and there is also some lesion in the dura that you can see right there. The dura is thickened, and the margins of the dura, the margins of the tumor at the dura are thickened as well. This was also they referred to it in the imaging report as the dural tails that you can see right there. And this is the T2 cut as well. With this, I just wanted to highlight that it didn't look as if the lesion was invading the underlying brain. You can see a small plane right there, which is also important to consider during a procedure. All right, so should we intervene? We have two different lesions, one in the kidney and one in the skull, and then radiographically it looked like an aggressive tumor. Our surgical goals was, of course, obtain tissue for diagnosis, then achieve safe maximal resection and bring the patient in and out safe. We need to consider neuroanesthesia. We need to have the neuro ICU ready in any case. of course, our navigation system. And in this case, because it was a bone lesion, we need to keep in mind that we'll probably need to do a cranioplasty as we do a craniectomy with dural reconstruction, because the lesion was coming, or looked like the component of the lesion was invading the dura, and our multidisciplinary team, both in the OR and out of the OR. On the differentials, Dr. Gupta already talked to us a little about them, but we can have metastatic tumor. We thought that the primary of the lesion was the kidney. We could also have meningiomas, any other primary bone tumor, or any other extraaxial lesion from the central nervous system. So we, Dr. Quiñones and Dr. Almeida, performed a frontal craniectomy with titanium mesh cranioplasty for removal of the tumor. So I'm going to show you the quick video here. It's only about a minute long. So the patient was positioned supine, the incision marked, then the skin incision was performed, the cutaneous flap was averted, and you can begin to see the tumor right there. A little piece was taken for the frozen section, and they continued to avert the flap with the periosteal dissector. They placed 5 burr holes that you can see right there, and then they connected them with the foot plate to begin the craniectomy. You can see that the tumor was very stuck to the dura. They spent a lot of time disconnecting the bone to the dura.
And maybe a comment right there, because I know that Vargas already commented on the veins, preservation of the veins, which was crucial, because especially in this dominant hemisphere, maybe just go back in just a second into those areas where yes, actually, we're going around the craniotomy. This is where we were concerned of avulsing one of those veins. You can see we're looking under. I don't remember if you, James and JP were there. I get in a chair and I come all the way under in a rolling stool, so that way I can see directly and try to leave a little bit of that dura. And then we went ahead and resected all that dura and put that patch right there, about complete preservation of those veins, which I think that's where we can get in trouble. You can see the defect right there. Now in retrospect, I think I should have done what Gabriel, recommended, which is the cement as well. He had a pretty good, healthy amount of tissue. We already knew in the frozen what we thought that it was. I didn't think he was going to need any more therapy. So I just went with a small mesh cranioplasty titanium right there. And we had a myocutaneous flap on top of this. So it was both the muscle and the skin. There you go. Those are the veins right there. So yes, there was a nice plane between the veins and the dura.
And they finished with the dural reconstruction with some fiber glue as well, and the titanium. So Dr. Gentoft, do you want to comment on the pathology?
Yes. So first, this is a gross of the lesion, or a gross picture of it. But before that, we had a couple frozen sections on this case. The first one, I couldn't make heads or tails out of what it was. And the second one, I could just tell Q, basically it was neoplastic. I couldn't tell if it was metastatic renal cell carcinoma. There was a lot of artifact, and in part that's because the biopsy is taken basically from the bone. I said it was a neoplasm, and he wanted to make sure it wasn't anything like a hematopoietic lesion or some sort of inflammatory lesion that wouldn't require resection. I said, no, it's neoplastic, but I can't tell what it is due to the artifact present. Then later on, we get this in the lab, and I had one of our PAs take a picture of it. This is a classic appearance of a meningioma involving bone. Actually, when I saw this, I felt like calling him up and saying, oh, I know now it's a meningioma, but I waited because I didn't want to say, oh, yeah, it's a meningioma, and then later on say, oh, wait, no, it's not. But it's a beautiful picture of basically a meningioma involving bone. So you can see how thickened it is. On a low power view, this is a scanned image. We've gone to scanning basically almost all our slides here and reviewing them digitally. You can see here, all the pink is actually bone. And the reason it's pink is we decalcify it because you can't cut it with a microtome with it having, being calcified. So we have to decalcify it, which takes a couple days sometimes before we cut it. But you can see here, the pink is basically bone, and towards the center, you see all the sort of purple bluish, that's the tumor. Now, if we go to the next slide, we can see on higher power, it has the classic meningioma appearance. You can see the pseumomatous calcifications. Now they're pink instead of purple. The one in the upper right-hand side, you can still see has a little bit of calcium. The reason for this is normally with meningiomas, we don't decalcify them. And that's why you see the purple pseumoma bodies, but here it's been decalcified and you can see the pseumoma bodies are pink. I actually stained this up, and the reason I stained it up is I had a portion of the case come out earlier that looked like meningioma, but I didn't have the entire bone because it had to decalcify. So I said, well, I'm going to go ahead. There was a concern for metastatic renal cell carcinoma. I'm going to have to prove that this is a meningioma and not a renal cell carcinoma. Granted, if I waited a day, I wouldn't have even had to do the stains, but I did them, and it was EMA and progesterone receptor positive, and it was negative for stains that are typically positive in renal cell carcinoma. So it's a meningioma. The Ki-67 labeling index was very low, and mitotic activity was basically non-existent. I struggled to find any mites. So it's a grade 1.
Thank you, Dr. Gento.
Just before we finish with Mark, I know that there's some more papers coming out about molecular markers of some of these meningiomas that are helping us determine whether or not we should do or consider more therapy and stuff like that. Did we send these for any sequencing? Are we beginning to send some of these tumors just for our colleagues and for everybody?
I do it basically upon request, because most of these behave pretty indolent. And then, when they return, if they do return, then that's when usually our neuro-oncology colleagues ask me to send it. It's kind of funny you say that, because Dr. Rosenfeld recently saw a patient where he wanted me to send an old case through. But I haven't been doing that typically. And there can be some issues with that. Some of it is reimbursement issues, because in most cases it's probably not necessary, but it can help considerably in some circumstances. My guess is in 5 years, my story will be, I send all of them.
That's what I figure. Yeah, no,
Yeah.
absolutely. Especially these ones, of course, or the ones that we're doing that are invasive in the skull base, they still behave indolent over time, but in the course of 15 or 20 years, eventually they ended up getting patients in trouble. And you start in your 40s when you have this issue, you're in your 60s, and now you're dealing with something that it's, potentially more dangerous.
Something that has always, bothered me and many other pathologists, even though it's true they're still grade 1, is these ones that, go into the bone or go out into the skin, even though they're indolent and, they might not be that mitotically active. I think it's probably more difficult to get all of it removed or to know where all of it is. And I always get concerned about that. And I think it's anecdotal. I mean, the studies aren't there to show it. And the studies actually show, that yes, they are grade 1, but it still bothers me, because any other tumor that invades is usually considered malignant. And if it's invading into the brain, the opposite direction, it's considered atypical or kind of pre-malignant. But the fact of the matter is they're still considered grade 1. Even though it's different than basically every other tumor in the rest of the body.
Now, in this particular case, we went all the way around, and bone that we knew by the surgical navigation appeared to be normal, number one. Number two, when we put the drill, it felt just like normal, cortical cancellous bone as we're going with the craniotome. And I think the picture that you showed shows that we are in normal bone. Is that what I gather also from the pictures that you show right there?
Yeah, it looks pretty much like you're in normal bone. On the far right hand side, it kind of goes towards some of the edge.
Yes.
However, you know, it was pretty much all removed. In the hyperostosis that you see, actually, you know, some of that is from an infiltrating bone, but some of that is just something that the tumor creates. So a lot of that is just bone up there without much, if any, meningioma in it.
Beautiful.
Yeah, it's actually interesting that from my own experience, and I'm sure this probably has been shown, all these sort of so-called what we radiographically call the intraosseous meningiomas, they're always grade 1. And they look kind of ugly, but sort of have a very sort of innocuous histological characteristics.
I saw one in Rochester, I'll never forget because the story is kind of good. That was anaplastic or malignant that went into and through. The guy had this lump on his head and it was ulcerating. And many of you guys may or may not know who the Green Bay Packers are, but they're a famous American football team in a very relatively rural community. And he hid it by wearing a Green Bay Packers hat, and he had it for years, and his wife didn't even know.
Amazing. Yeah, no, we have seen some of this, but go ahead, Vivek, you were about to say something?
No, I'm all right. Yeah.
Beautiful. Let's see what the post-op shows.
So this is the post-op scan. This is the T1 with contrast axial cuts. So you can see that the lesion grossly was removed completely. And there was a small serosanguineous fluid collection in the area of the surgery that you can see better in the T2 right there, measuring about 6 millimeters. But other than that, the scan looks unremarkable. All right, so the post-op course, post-operative day 1, there were no acute events overnight and the patient was feeling clinically well. Post-operative day 2, same, no acute events overnight. There was also minimal output from the subcutaneous drain that was placed during the surgery, and that was removed on that day and the patient was discharged home.
It's actually subgaleal drain, remember? Subgaleal, yes.
Yeah. So that was the case. Thanks everyone for coming today.
Just to one last teaching point that I think Gabriel brought up, and I think is very important, and so did JP. You know, I should consider putting also cement on that. So you just remind me, I'm just gotten so used to just putting the mesh, you know, and stuff like that. But I think that eventually you need something and you need to give radiation and stuff, that skin sinks into those little holes. It doesn't take it takes another 10 or 15 minutes on the side, actually, simultaneously as you're doing the surgery, to be able to just shape that cement around it. It's very nice and smooth, and then you put it right there and it looks beautiful. So very good point. Just for our residents. Anything else, Gabriel, that we could consider?
Oh, congratulations for the cases, good cases. Congratulations.
Beautiful. All right, what do we have, Andres? Is this for Monday?
Yeah, for Monday we have Dr. Neymad from the University of Louisville. He trained in Harvard and went to Vanderbilt, and then he's a chair at the University of Louisville in Kentucky. So he'll talk to us about curved trajectories in stereotactic neurosurgery.
Joe is a very good friend, Dr. Niemann, so I'm excited, and I think that looking forward to saying hi to him and hearing his talk, and hopefully many of you guys will be able to join us. So good. Thanks, everybody. Gabriel, Vivek, Jennifer, Dr. Peterson, thank you, and all the residents and our fellows for putting these cases together. They're beautiful teaching cases and illustrations of some techniques, and we get to learn from each other and all the people from around the world. So many 12 different countries joining us this morning. So Much, much gratitude. Have a wonderful and safe weekend. And if you have an opportunity, do CNS. CNS stands for cigars and spirits. All right. Just joking. Good. Gabriel liked that one. Good. All righty. Very good. Have a good weekend. Take care. Bye-bye.
Bye bye.